Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features expert-led discussion on key aspects from the NCCN Clinical Practice Guidelines for CLL and strategies for applying these recommendations into your clinical practice. I'm joined today by Drs. Danielle Brander from the Duke Cancer Institute, Brian Hill from the Taussig Cancer Institute, and Deborah Stephens from the University of North Carolina. This episode is part of a larger educational program titled Applying the Latest Evidence in NCCN Guideline Recommendations in Chronic Lymphocytic Leukemia, Small Lymphocytic Lymphoma. For more information on Drs. Brander, Hill, and Stephens, along with a link to the complete educational program, including downloadable slides, please visit the show notes for this episode. Now let's get started.
So before we get into the treatments themselves, just a few general points about prognostic markers. And of course, over the years and decades, this really has evolved from what was initially just staging systems. Then with the bulk of patients being early Rayer-Benet stage, we've moved to biomarkers, namely for CLL. There is a whole book or a whole talk that could be given on biomarkers, I think narrowing down to the key FISH, IGHV, and TP53 mutations. Rather than just looking at the individual markers, I think particularly as you're sitting down with a patient after diagnosis, is understanding potentially time to first treatment. So the CLL IPI score, as many are probably familiar with, is a weighted score looking at some of these markers we talked about, the 17p or TP53, the IGHV, clinical stage, age weighs in there, and beta-2 microglobulin. And these weighted scores can sum into a total score being low, intermediate, high, or very high risk. And while again, the figures at the bottom on the left of overall survival are likely underestimated with therapies, what we talk a lot about now in that bottom right figure is time to first treatment. And I think CLL IPI score certainly can be helpful in talking to patients about their likelihood of needing treatment in 2 and 5 years. And though a bit beyond what we'll talk about today for options for therapy, I think we recognize that potentially these higher risk patients, those likely or very likely to need treatment regardless, are likely the patients also that may be suitable for early intervention or early intervention trials. So with the importance of B-cell receptor signaling, particularly in CLL and keeping cells alive, of course, years ago had the advent of BTK inhibitors, namely covalent, so binding irreversible or the first generation ibrutinib, second generation acalabrutinib, and zanubrutinib. And then, as just mentioned, non-covalent BTK inhibitors just becoming available for patients with CLL as well, with activity even with first generation, second generation covalent resistance. Of course, anti-CD20, like other B-cell malignancies, important in targeting. And then BCL2 inhibition with venetoclax or other similar mimetics that disrupts the anti-apoptotic balance. And so when you put it all together, this is the top figure for patients without 17p or TP53, the bottom with, and thinking of the preferred regimens, the other recommended. And then, of course, always in our complex patients, there are certain circumstances we still consider some of these other agents. But as highlighted in the blue, you'll see the covalent BTK inhibitors. And so amongst preferred regimens for patients would be either the second generation BTK inhibitor, and in the case of acalabrutinib with or without obinutuzumab, and then venetoclax, obinutuzumab, or zanubrutinib. And as mentioned, as we'll see from the patient case we discussed, again, no head-to-head frontline studies that we use to say that these covalent BTK versus venetoclax-based regimens superior or not, but really takes in the considerations in meeting with your individual patient, which we'll go through here. So what are these key components sitting down with patients that need frontline therapy and deciding between these highly active regimens? So of course, patient-specific factors have always played a role. Now, not so much do we think of CLL therapies. Before, there was certainly an age cutoff we often kept in mind. Unfortunately, with the newer therapeutics, for the most part, they've been studied across age range and, as I say, how experienced patients are in life. But certainly other comorbidities may factor in as we talk about what these drugs' side effects or toxicity profiles are. But also, of course, if patients have, for example, renal dysfunction, then things like tumor lysis can become a higher risk or higher problem. And lastly, there are concurrent medications. Now, a lot of times I think we think of direct drug-drug interactions, which of course there can be, and drugs would have to be modified for that. But more thinking too along overlapping toxicities, for example, BTK inhibitors and bleeding risk. And while not certainly a contraindication for a patient on antiplatelet or anticoagulation to go on BTK inhibitors, certainly can factor into that equation. Then are the disease-specific factors. So as the patient we discussed had 17p or TP53, I think many, I don't want to say all, because you still are considering patient-specific factors, are favoring a continuous BTK inhibitor approach for patients with 17p or TP53 as frontline therapy, with this thought of the chronic, suppression of this clone rather than fixed duration of therapy. But disease-specific factors I also consider not just, of course, the molecular or genomic details of the leukemia, but how is it presenting in this patient? How is their CLL, SLL distributed? Of course, for all of those that said in multiple patients with CLL you see in a month, I think you probably could all agree they all tend to present slightly different. Some with bulky lymph nodes is the reason for treatment, others cytopenias. And that may weigh into your decision as venetoclax obinutuzumab, much faster, I would say, rates of, clearing out the bone marrow or MRD, whereas bulky lymph nodes may not get to as much or may favor into tumor lysis, and so much the reverse for BTK inhibitors. And then, of course, the regimen-specific factors. We talked about some of the toxicities, but I think certainly I never presume which patient, I think still surprised, would be totally fine with almost indefinite BTK inhibitor therapy versus the patient who wants to do fixed duration. Certainly, if patients are working or not, their resources to get to the center may factor into that as well, into the feasibility. How do you manage patients with these BTK inhibitor-specific toxicities? And I think there's two parts to management, right? There's if the patient develops the toxicity, but then in these long discussions of selection of therapy, I think there's certainly ways to mitigate the risk before patients start. So particularly for hemorrhage or bleeding risk, as I mentioned, considering patients already on a anticoagulant or antiplatelet therapy, their risk is going to be higher of bleeding, but it's not completely excluded. Others may do this differently. For me, if patients are on one anticoagulant, and I should mention across all these studies, patients on Coumadin or warfarin were excluded, so I do not have patients maintain on that. But for other anticoagulants plus BTK inhibitor, I think can be manageable. What I try to avoid is starting to compound that with then another antiplatelet agent or a third or fourth. And also just keeping in mind, these aren't just prescription drugs, right? So many of patients, the deeper we or often our pharmacists or wonderful nursing teams identify as patients are on supplements that can increase bleeding risk, such as fish oil, et cetera, and really paring down on what is necessary or not. So management of this is both planning, risk mitigation, and of course management if patients develop it. And amongst that planning, patients, I think, are really great when we tell them to let us know if they have a planned surgery or procedure so that this can be held appropriately. In terms of infections, of course, there is low, but certainly recognizable risks of opportunistic infections with inhibitors. Again, in this risk mitigation, thinking of things that increase that risk, so prolonged higher dose steroids if patients are already neutropenic when starting. Think about these patients as being much higher risk and trying to mitigate that. Atrial fibrillation or flutter is not a strict contraindication, particularly if patients are asymptomatic and continuing on the therapy. But I think certainly working closely with cardiology and understanding what this means for the patient, how well it's controlled. And of course, recognizing if there are potential for agents to be used to control their atrial fibrillation that don't interact with therapy, whether it be staying on the BTK or whatever you switch to. I think cardiologists in general or cardio-oncology are very willing to work together to find the best for the patient. And then hypertension, as well. And here is not something, fortunately, unlike other cancer therapeutics where patients go from normal blood pressure to sky high, often happens with time, but happening with time can also, I think, sometimes be sneaky, and it's easy amidst everything else to cover for hypertension not to be the star of the show. But as patients are living longer directly from their disease, I think mitigating their cardiovascular risk and blood pressure control is important. And so just encouraging patients to track that and working with primary care. One of the things with venetoclax, whether in the relapse setting or in the front line, is close and careful tumor lysis risk monitoring and this dose ramp-up schedule. So you see here what it would be for a patient, for example, that had no drug interactions, so was starting at 20 and getting up to 400. And most patients, since in the frontline setting they receive obinutuzumab, their risk for tumor lysis comes down, and this can be done as an outpatient if they're low or moderate risk, but of course keeping in mind things like renal dysfunction, remaining bulk of disease, as some patients even in the frontline setting can benefit from initial doses inpatient.
How do you think about mutations in terms of treatment with BTKI or VEN?
So for BTK versus venetoclax, I don't, unlike the TP53 or 17P, I don't lump IGHV and pushing patients one way or the other unless they're completely undecided. And then we continue the conversation and say, well, you might have a slightly shorter remission off of therapy if you're IGHV unmutated if you do fixed generation venetoclax. But it's pretty uncommon where things get to that tipping point. Often patients either have other comorbidities or other reasons where, again, in risk benefit, you might lean one way or the other. So I think it's important to know for patient expectations and also monitoring them off of therapy. But I don't think it's enough to, be the sole thing that's tipping the scales like TP53 or 17P.
Fair enough. Excellent. Well, so I think we'll move on to Dr. Stephens.
Okay.
Thank you. And she's going to be talking about considerations in selecting therapy for previously treated CLL.
I think, Dr. Brander had described what she uses as guidelines for trying to determine what's the most optimal frontline therapy, including, patient selection, their comorbidities, their different risk factors. And I think, of course, in subsequent lines of therapy, one really important piece to add into is what was the initial treatment or treatments. Did the patient have prior chemoimmunotherapy? Did the patient have prior venetoclax and obinutuzumab as a time-limited therapy? And if they had this, how long was the remission since the time of receiving this therapy? If a BTK inhibitor therapy was given continuously, what was the reason for discontinuation? Did the patient discontinue because of resistance of disease, or was there intolerance to one of these BTK inhibitors? And so when you think of these, putting these things all together, one thing that I often, have to explain to patients is that when disease starts to relapse, these patients are kind of, back in that watch and wait period that they were most likely in when they first started their journey with CLL. And so just keep in mind that just because their ALC starts to rise or because they develop lymphadenopathy, outside of having symptoms or other cytopenias, you really still can continue to observe these patients. Even patients, maybe they're progressing on a BTK inhibitor therapy, but they really have no clinical symptoms that require a change of therapy. You can continue to observe or could just continue them on their continuous BTK inhibitor therapy. But, in the case of this particular individual, he was having fatigue and symptoms related to his CLL, so treatment was indicated. And then again, you can kind of split this out by, did they have prior chemoimmunotherapy? And in that case, you have the option of all of the targeted agents, such as venetoclax and CD20, acalabrutinib, zanubrutinib. If they had a previous BTK inhibitor therapy, could switch over classes to venetoclax-based regimen, or maybe they were on ibrutinib and they discontinued due to intolerance. They could still be a good candidate for BTK inhibitor therapy with an alternate BTK. If they had prior BCL2 inhibitor therapy, such as this individual, they also have option of second generation BTK inhibitors, or you might consider retreatment with venetoclax. And I'm going to go over data to support either of those approaches. Dr. Brander highlighted and already mentioned this study, but I think it's really critically important because it helps to guide our therapeutic choices on a day-to-day basis. So the Elevate-RR study was a phase 3 study, and this was specifically for a higher risk population of folks with relapsed or refractory CLL. And this was defined in this study as having deletion 17p or deletion 11q. So it is a subset of the relapsed or refractory CLL. These patients were randomized to receive either twice daily acalabrutinib or once daily ibrutinib, and these therapies were continued until progressive disease or unacceptable toxicity. Just want to highlight the primary endpoint of this study. The goal of the study was to determine if acalabrutinib was non-inferior to ibrutinib in terms of progression-free survival. And the study did in fact meet its primary endpoint, and you can see these progression-free survival curves here, and they're essentially overlapping between acalabrutinib and ibrutinib. Even the hazard ratio was 1.0, so really very similar. Again, met its endpoint, showed that in these patients, in this population of deletion 17p, deletion 11q patients with relapsed CLL, they had a non-inferior progression-free survival when you're comparing acalabrutinib to ibrutinib. Of course, the bigger ticket item for this study and what makes it so important is the difference in toxicities. And you can see here that the ibrutinib arms are shown in the red color. The patients receiving acalabrutinib are shown in the blue color. And what these graphics show on the left-hand side, it shows a lower cumulative incidence of any grade atrial fibrillation. And then on the right-hand side also shows a lower rate of hypertension with acalabrutinib, which is really important. These patients are often on these drugs for a long time, and you find yourself managing a lot more hypertension as time goes on. And so you can see that acalabrutinib causes less of this. Acalabrutinib was also associated with lower rates of bleeding, diarrhea, arthralgia when compared with ibrutinib. Another important study that Dr. Brander introduced is the Alpine study, which is a similar but not the same group of study as the one I just spoke about. This is the Alpine study. I want to highlight a few key differences in this. This study is also for relapsed or refractory patients with CLL. However, these individuals could be any different subgroup, so they didn't have to have any specific molecular markers to enroll on this study. If you remember that the Elevate study had the 17p and 11q, and this is just all patients whose disease had relapsed after therapy. These patients were randomized to receive zanubrutinib twice daily versus ibrutinib, and again, continued until progressive disease or unacceptable toxicity. Another key difference in this particular study than the Elevate study that I just spoke about is the primary endpoint is a different primary endpoint. They were looking at non-inferiority and superiority of overall response rate. And other endpoints are listed here, but of course this progression-free survival, which was the primary endpoint of the Elevate study, is one of the secondary endpoints here. Despite that, the Alpine study did reach its primary endpoint, which was to determine that its overall response rate was superior to ibrutinib. But I think the bigger ticket item here is the progression-free survival curves, because what I think was a little bit surprising is that zanubrutinib also did show a superiority, an advantage, a longer progression-free survival. So zanubrutinib curve is here in blue, and the ibrutinib curve is here in this red-yellow color. And, over time, we have started to see these curves separate out a little bit. And I'm very excited to say that the 3-year data is going to be presented at this year's ASH. And so that's a really, I think, important abstract to check out because, as we see, the question is, over time, are these curves going to continue to separate? Is there a certain time point where they will overlap? And so I think long-term follow-up is really important for this patient population. There's a little bit of difference in the side effect profile as well seen here. And when you look at the left-hand column, the ibrutinib again is shown in the reddish yellow orange color. Zanubrutinib is in blue. You can see that much like acalabrutinib did, zanubrutinib also showed a decreased cumulative incidence of any rate atrial fibrillation. However, when you look over at the hypertension curves, zanubrutinib and ibrutinib were very similar in terms of the rates of hypertension. So, a little bit of distinction there in the side effect profile, potentially related to off-target toxicities. But, if you have a patient that has very hard to control hypertension already, you might want to consider this because, potentially could acalabrutinib be a better option for those patients. And so, some key differences in the studies there. But, a lot of people have the tendency to say, well, in the Alpine study, zanubrutinib was superior to ibrutinib. In the Elevate-RR study, they were very similar drugs. So can we, just extrapolate that zanubrutinib is a superior drug to acalabrutinib? And just because of the differences that I highlighted out and the difficulties with cross-trial comparison, we really can't say that. And these were different patient populations with the studies slightly different goals. However, when people ask that question, is zanubrutinib a better drug? Again, no direct comparison, but when you look at PK data, there may be some suggestion of why it potentially could be a more potent drug. What I'm showing here are IC50s of the drugs, and those are all shown with the red line. And what you see here, the darker blue curve here, is acalabrutinib given at the recommended dose of 100 milligrams twice daily. And you can see that the curves with the dosing, you get a spike up above that IC50, then it drops and you get another spike. And this drug is above IC50 for about 8 out of 24 hours in this particular study. When you look at ibrutinib dosing, of course, that's a once a day dosing. You can also see that, that spikes above the IC50 for a portion of the day and then kind of drifts down over time. And this is above the IC50 for about 6 out of 24 hours. And then when you look at zanubrutinib data, you likely know that even though most of the studies looked at twice daily zanubrutinib at a dose of 160 milligram, which is shown in purple here, there's also another recommended dosing, which is just to give all of it at one time, the 320 milligrams, which is shown in yellow here. Now, these curves, you can see they're completely above the IC50 for 24 hours. And so some people have pointed to this as maybe, potentially a PK explanation for why this might be a more potent drug. Now, the question becomes, these are covalently bound drugs. So does it matter how high they are, how long they are above the IC50? We don't really know, but, just pointing out the data that may support it could be a more potent drug. However, Dr. Brander also showed these kinome maps. And as you all know, these kinomes, the red dots indicate the kinases that are inhibited. And you can see over here, this acalabrutinib, this is kind of the best representation of where BTK is. And you can see that with each of the drugs, that zone is very well covered. However, there are off-target effects of these drugs. Now, some off-target effects might be desirable off-target effects, but you can see a lot of times they end up turning out to be toxicities. And so you can see that in this depiction, acalabrutinib is really the most focused BTK inhibitor. And so I feel like in my practice and when I work with patients, I do note toxicities are different between these drugs. And I often find that acalabrutinib is very well tolerated. I'm really, picking at, strands here because all of these drugs I do feel are quite well tolerated. And often, you just have to get patients through that first month of their bodies adjusting to the drugs, and they really do quite well after that. So I just wanted to open it up to you guys, Dr. Hill and Dr. Brander, just asking you guys how you choose between the approved covalent BTK inhibitors in the relapsed or refractory setting.
I guess I'll start and just say that I agree with a lot of it does depend on what they've previously been treated with, but if they're BTK inhibitor naive, then I think we're really just left with acala or zanubrutinib. And the choice between those, I agree that I don't think that we can say that one is clearly better than the other. They have different toxicity profiles. I think many folks who use a lot of these drugs sort of pick one and stay with it because they get comfortable with it and then only change if there's an intolerance. So I'll turn it over to you.
Yeah, I think similar. Again, it's a good problem to have, I guess, to have more than one option, but I usually at least just lead with the fact that, as you pointed out, they are two different studies, so I don't think we can say one is superior. Sometimes I'll have and so basically it's trying to look for anything will maybe tip you one way or the other, which can be hard, but even though the relapse trial did not combine acala with anti-CD20, if I have a patient with an autoimmune problem or somewhere where I want to do a BTK plus that, sometimes I'll still go with acalabrutinib. I know some have reported headaches may be less with zanubrutinib. I certainly still have had some patients with that, but it may be less. And so, but that's a manageable side effect, but I've had that kind of tip the scales sometimes for patients. And though it doesn't come up a lot, occasionally there is a difference, of course, in cost or securing of drug for a patient. They all have different insurances, all reasons. So trying to keep all of that into account. Like I said, a good problem to have, but can be hard to tip the scales between the covalent BTK, because I think they are pretty similar.
Yeah, I agree. I think it is just a really good problem for patients to have, as having multiple very good and efficacious drugs to choose from, and you really can tolerate. You can tailor treatment to the individual patient. Just mentioning some of the side effects. For example, acalabrutinib is very high rates of having headaches. So if somebody has an issue with chronic headaches, might not be the best choice for them. Again, with zanubrutinib, if people have uncontrolled hypertension, it might be a better choice to go with acalabrutinib. So, but either way, I think these drugs are very well tolerated. And so I think these patients have some very good options to choose between, and you can discuss the side effects of each. So the important study here is the Murano study, and this study paired venetoclax with rituximab. This study now has had several updates, and you can see that the difference in PFS, which the blue curve is venetoclax and rituximab, and the red curve is bendamustine and rituximab. Not surprisingly, the PFS is much, much longer in patients treated with venetoclax and rituximab. I've also shown that people who are able to get a deeper response over on the right-hand curve, and this is measured by amount of detectable minimal residual disease, and those folks who achieved the deepest level of undetected minimal residual disease are shown in green. They do have the longest PFS. Now, this is the study that really gained approval for venetoclax in combination with CD20 in the second-line setting. And so what we don't have at this time point is a study looking at venetoclax and obinutuzumab in the relapse setting. So I think it's really critical. I mean, sometimes we have to use data from other studies, and Dr. Brander talked about the CLL-13 study, which was frontline, which compared venetoclax rituximab to venetoclax obinutuzumab. And we have multiple studies that show that obinutuzumab is likely a superior antibody in the treatment of CLL. And so, a lot of people, if insurance will allow, will actually give obinutuzumab in combination in the second-line setting as well. But sometimes insurance companies really, stay on the line of the phase 3 randomized data, and this is where the Murano study comes in. And they may only allow you to give rituximab in the second-line setting. One thing that was a little bit different about this particular study, too, is that they started with the venetoclax ramp-up. And so, with your highest tumor burden, you start with the venetoclax ramp-up during the first month and add rituximab later. Whereas if you recall from when Dr. Brander was talking about how obinutuzumab and venetoclax are given in the frontline setting, you have 3 weeks of obinutuzumab treatment before you get to the venetoclax ramp-up. And so, if I am choosing to give venetoclax in combination with rituximab, I often will start at the same time with the rituximab, just because I do think that does help to debulk the patients and put them at lower risk of TLS. I do, again, try to use venetoclax with obinutuzumab if insurance will allow, even in the second-line setting. Dr. Brander showed the frontline NCCN guidelines. The second line or third line and subsequent treatments are actually very similar in that the targeted agents of acalabrutinib, venetoclax, and zanubrutinib are all the preferred regimens for these. And again, we are often sequencing these regimens depending on what a patient was treated with during their first line of therapy.
So I have a question. If you can be thinking about the second line as you're finishing the front line, do you ever think about the order, starting with the BTK and then to BCL2 or vice versa?
Yeah, and I think that is one area that I just commented on. I think it's very hard to get prospective data to support which drug should be used first for which patient. And so I think, a lot of that is, just your clinical sense and your discussion with the patient about their side effects, their social situation, their preference in terms of therapy. And some of it is really guided by, when did the patient need treatment? And so, of course, like, for example, ibrutinib was approved around 2014. So a lot of people who got frontline therapy in 2015, 2016, ibrutinib might have been their frontline of therapy. And so, some of it is just guided by what are the available agents at the time. And, of course, we've had patients still that have been treated with multiple different rounds of chemotherapy. And so I always like to try to think about the sequence for these patients. And so I often, pending no TP53 mutation, and even sometimes if patients do have it, if it's a younger patient, I might lean more towards a venetoclax-based regimen in the front line, just because I know that they're going to have a long time to live with their disease. Maybe having a time-limited therapy up front is more desirable, and then can sequence after that. As we get more and more data about sequencing venetoclax, another round of venetoclax therapy, that might be an option. New drugs are getting approved all the time, as just evidenced by the recent pirtobrutinib approval. And so I think it's important to think about next lines of therapy, but I think that's a big debate, right? Because when we started thinking about, okay, BTK inhibitors, these are great drugs. BCL2 inhibitors, these are great drugs. Should we just use them all at once because maybe we can cure people with CLL and then we don't need to think about all these sequences of therapy over time. And then, new drugs come into the scene like pirtobrutinib, and it's like, well, should we be using that in frontline setting? And you think, well, the people who have resistance mutations might not be able to respond to some of the other BTK inhibitor therapies. And so it's definitely an active, discussion with patients. And I think the hard part is it's very fluid. It changes as different drugs get approved.
Fantastic. Well, maybe one more question. I'm actually going to lump two of them together about venetoclax. And as you mentioned, even in the relapse, you try to pair with obinutuzumab. I certainly do, and I think Brian probably does as well. So if you're using obinutuzumab with venetoclax in the second line, can you just comment? One is asking, do you change the schedule or maintenance of using obinutuzumab when in the relapse setting? So one is about how you pair it and schedule. And then the second question is, even after, if patients are exposed to a BTK inhibitor before they go to venetoclax obinutuzumab, do you expect that to give a better response post-BTK than Ven-R?
Okay, a lot of parts to that question, but so in the relapse setting, I use obinutuzumab up front. So I do the initial schedule, that initial 6-month period is the same as for frontline. So I start with the venetoclax or the obinutuzumab and do, the 2 doses split over 1 day and then a couple of weekly doses before I start the venetoclax ramp up. But then I actually do go for 2 years with venetoclax in the second line setting. I didn't really highlight that piece, but the Murano study was 2 years of venetoclax therapy as opposed to 1 year, which was in the CLL14 study. But in the relapse setting, I do go ahead and extend that out for 2 years of treatment in the relapse setting. So kind of a big extrapolation of different pieces of studies. And then the second question was,
with using obinutuzumab venetoclax, do you expect using obin is going to get better responses than using rituximab if patients have already had a BTK?
Yeah, I definitely do. I still think every study that has compared obinutuzumab directly to rituximab, it seems like a better drug, more efficacious, deeper remissions with obinutuzumab. So I do prefer any time that I can use it in any setting.
I also just want to add that although venetoclax, most of the studies have been done in a time-limited fashion, the original study was continuous therapy until progression or intolerance. And there's nothing that says you have to stop venetoclax. So I wonder sometimes when we see these things that, it doesn't work well for 17p, maybe we shouldn't have stopped it, because it's really... If you I have patients been on venetoclax for 6 years, and there's no reason you can't do it. There's no described long-term toxicity.
Yeah. And in fact, one of the first studies was the 17p or TP53 patients, and it was given continuously there.
Okay, so for those who are just joining, we're going to talk about novel strategies for CLLs. So I'd really like to focus on where we are in this kind of top 2 parts of the display here, which is what do we do for these people who are double refractory? So double refractory really means you've been through a BTKI and you had to stop it presumably for disease progression. Intolerance is sort of a little bit of a different issue. And you've also developed disease resistance to venetoclax. And what do we know about these patients? Well, they do poorly, as you might imagine. So on the upper left, this is all data from a single real-world consortium paper that described the sort of real-world FS of about 8 months in this group. And on the lower left, to the point I was making on the prior slides, those people on the green that had been treated second line, that had prior chemotherapy and then had sort of subsequent BTKIs, those and BCL2 inhibitors, those patients have the worst. And the overall survival on the upper right, you can see, is only a median of about 2 years. So there's a lot of room for improvement in the double refractory patients. So what can we do? Well, we could put the two drugs together and do a combination. We could do novel approaches. Cellular immunotherapy has revolutionized the treatment of other B-cell malignancies. Why can't we do it more for CLL? PI3 kinase inhibitors have been attempted, alternative BTK inhibitors, and bispecifics. So going back to our guiding document, which is NCCN Guidelines against second line or third line therapy, we talked about it preferred, but I really like to focus on the bottom, which is those for double refractory patients. So they've had prior BTK and venetoclax. And you see a list of many agents, but I would like to focus on pirtobrutinib. During the talk, we'll hear about this, especially in light of the recent FDA approval for CLL. So what about alternative BTK inhibitors? So what we've been talking about all morning are the covalent BTK inhibitors. So to remind the audience, BTK mediates downstream pro-survival signals by phosphorylation, phospholipase C gamma. PLC gamma then propagates pro-survival signals to the nucleus. This B-cell activation and proliferation is why BTK is such a potent target. And we know that all of the covalent BTK inhibitors bind to cysteine 481. So this applies to ibrutinib as well as acalabrutinib and zanubrutinib. The problem is that, as we've been alluding to, that this renders a tremendous selective pressure on a single amino acid that, if mutated, leads to complete lack of activity for all of the drugs. And so if you, and this test is available through many different CLIA-certified labs. So you can test from the blood for 41 and other mutations that render covalent BTK inhibitors resistant. So I would point out again that if ibrutinib stops working and you have this mutation, there's no reason to expect that acalabrutinib will work or zanubrutinib will work, and really should not be done. But we do have another option. So non-covalent BTK inhibitors bind to a different pocket in the target and lead to inhibition of activity. And so the one that we're going to discuss today is pirtobrutinib. And this, I would just point out that the only problem with this approach is you can still have activating mutations downstream of BTK, and this probably leads to some of the reasons for resistance even to pirtobrutinib. So let's talk about pirtobrutinib. So this is the Bruin trial. This is a phase 1/2 study of a dose escalation and then a large expansion for patients with B-cell non-Hodgkin lymphoma, including a large number with those with CLL, SLL. The primary endpoint of the phase 1 was the recommended phase 2 dose, and ultimately in the phase 2 it was settled at the current now approved dose, which is 200 milligrams daily. This was the publication of the CLL cohort of 247 patients with a median age of 69, 3 median prior lines of therapy. And I should point out that this publication really just focused on all patients who went on this study had to have had previous therapy with a covalent BTK inhibitor. And you can see the vast majority had prior CD20-directed therapy. The vast majority had chemotherapy, and 41% had prior venetoclax. At the bottom, you can see the frequency of those tested, which is actually the vast majority. 222 patients were tested, and 38% had a C481 mutation. There were 8 patients with identified PLC gamma 2 mutation. In terms of AEs, the drug is remarkably well tolerated, with bleeding and bruising rates that are similar to the covalent BTKs, but I would say very low rates of high-grade bleeding or bruising. The sort of neutropenic and infectious complications were not unexpected in this heavily pretreated patient population, and I would highlight the extremely low incidence of atrial fibrillation. This is the waterfall plot that shows the change in the sum of the product of the diameters, which showed that the vast majority of patients had clinical benefit. And on the left-hand side, you can see the waterfall plot, where I would highlight those who had, in blue, discontinued the covalent BTK due to progression and those who discontinued due to toxicity or other reasons. And you can see that there's sort of equal distribution of depth of responses for patients who discontinued for each reason. Median PFS is shown here as 56% at 18 months, and median follow-up 19 months, but the median PFS is 19 months with 56% at 18 months. Here's a subgroup analysis that shows the overall response rates, and the scatter plot demonstrates that those with CA41 mutation actually had as good or better responses than the average patient. The only sort of potential indicator of a lack of response is PLC gamma 2 mutation. And again, if you compare the reasons for discontinuing the BTKI, whether it was for disease progression or toxicity, actually very similar and very high overall response rates.
We have several audience questions, so let me throw a few of these out. I might combine some of them. This one's for you, Dr. Hill. With NGS available to test for BTK, BCL2 inhibitor, and I'll say PCL gamma 2 resistance is available, how does this guide your choice in the relapsed or refractory setting?
Yeah, I think that's a great question. As was mentioned, certainly if you have a patient with progressive disease on a covalent BTK and you identify C481 mutation, you really should not give another covalent BTK. So that, number one, is very helpful. The other thing I think we need more data on is the role of PLC gamma 2 mutation. So if you have an activating mutation there, an upstream inhibitor may not be the best. So pirtobrutinib may not be as good of an option as venetoclax if they have not previously been treated with venetoclax.
And do you get these in all of your patients before you start new therapy?
Yeah, typically in previously treated patients who are progressing on a BTK, yes, I do send that panel.
And I would, I guess, add too, I know it's not standard, but if you have a patient that came off due to intolerance of like ibrutinib, I also think for select patients, it might be helpful. I don't test for these mutations if they're not clinically progressing, but maybe they came off due to a side effect and then they're relapsing. And I've had a few patients that had the mutation, even though they weren't clinically progressing, and versus switching to another BTK versus now that we have all these other agents available, something I think needs studied, but may have a role there too. So you're not newly starting a therapy that may not work for as long.
Yeah, great points. Another question for you, Dr. Hill. What about stem cell transplantation for relapsed or refractory CLL? And kind of a side question about this, what about those younger patients that might need a transplant? Does that affect your choice of sequencing therapies?
Yeah, so allogeneic transplant was previously done more commonly in the 17P in the high-risk patients. There's very limited data in the novel therapy era to say that it works well, although I would sort of anticipate that we would see similar outcomes, which is a certain proportion of patients achieving long-term remission, with the caveat that there's always high rate of uncertainty in terms of long-term toxicities with graft versus host disease.
Okay, this one's for you, Dr. Brander, something we didn't talk a lot about. Why not consider ibrutinib venetoclax as a recommended option for frontline? And if you would, who would be your ideal patient?
At least for us and our patients in the U.S., it's not an approved combination. You have two expensive drugs. Just logistically, I think recognizing that that's not yet approved. But the second part is really understanding which patients benefit versus there are higher toxicity rates. And if you're also already wanting to use a second generation BTK, going back to using ibrutinib by itself, which can have higher toxicity, and combining with venetoclax can be difficult. But like I pointed out, and Dr. Hill pointed out, in our current era, patients can have such long remissions from frontline or control from frontline therapy of ven alone or BTK alone that combining them, I think we have to be cautious. To your point, I think the patients that if you were using either ibrutinib or if we're seeing other combination trials, of course, there are cooperative group studies combining venetoclax with acalabrutinib for example, then I think it's the younger patients or the higher risk patients, the patients where you're really trying to get them a deep response and then potentially time off therapy, where they may have immune recovery or other, financial or toxicity benefits. So a higher risk patient, a younger patient is probably where you would consider it. Also, Dr. Hill pointed out that venetoclax frontline, the way the trial was designed, was fixed duration 1 year, and higher risk patients are probably not going to get as deep a response after 1 year. Maybe they don't have to continue it forever, but maybe a combination or continuing it a little bit longer would get them just far enough to the point where then when you stop, you're going to have longer time off of therapy. So,
and all very good points. And I think a question that wasn't asked, but I often get is, because, we also talked about CD20 monoclonal antibodies. And so, if one drug is good, is 2 drug better, and is 3 drug even better? And I think we actually have data now that potentially 3 drugs could be more toxic, at least for the elderly population. Dr. Woyak just presented results of the Alliance CLL study for the older patients with CLL. And this study, the accrual was actually the 3-drug arm with ibrutinib, venetoclax, and obinutuzumab was actually stopped early because there were more toxicities, and just during the time there were more deaths and COVID-related complications. And so, I think we have to be careful about being aggressive about trying to load all of these drugs onto the patients, and just keep in mind that they do all come along with their own set of toxicities. Okay, maybe one more question for Dr. Hill. For Richter's transformation, is there good data to add BTK inhibitor therapy to chemoimmunotherapy?
Short answer is no, not great data, but I think a lot of it depends on if the patient had prior treatment for their Richter's. If it's a patient with previously treated CLL that hasn't been exposed to a BTK inhibitor, and now they've presenting with Richter's, there are some data that show even just single agent BTKIs can work. The problem is nothing really works very well, very reliably, so it's always a little bit of a sort of quick trial and error experience with Richter's to find something that might stick. Agree with that? Or
yeah.
You do a lot of Richter's too, yeah. Dr. Stephens. What is your thought on that one?
Yeah. I think, again, it's, we do a lot of Richter's treatment. Probably if there was a gold standard for Richter's, it would be RCHOP. And you probably know that's based on like an arm of a study that only includes like 20 patients with Richter's. And the data looked good in that arm, but, I think still that should be an area of active investigation of how to best combine these agents.
Thank you, Dr. Sprander, Hill, and Stephens, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, applying the latest evidence and NCCN Guideline recommendations in chronic lymphocytic leukemia, small lymphocytic lymphoma, and to claim credit for listening to this certified podcast, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology and hematology topics.